Well, hello and welcome to our Winship Webinar today, Role of Palliative and Supportive Care in Oncology. We're glad you have joined us. We have with us today Dr. Kimberly Curseen and Dr. Ali Zarrabi. Dr. Curseen is the director and the primary provider for the Supportive and Palliative Oncology Care Clinic at Winship. She is part of the clinic team providing physical, emotional, and spiritual care for patients with cancer at any point in their disease process, and in assisting patients with complex decision-making. Dr. Zarrabi is a supportive and palliative care researcher. His research involves developing models of care to address the unmet needs of seriously ill patients, specifically pain, addiction, and emotional suffering, and in examining how these interventions can improve patients' quality of life. He is also part of the care team providing physical, emotional, and spiritual care for patients living with serious illness. Today, they will be discussing the role of supportive and palliative oncology in a multidisciplinary team setting. But before I hand it over to our presenters, please note that we will have time for a short Q&A at the end of the presentations. Feel free to submit your questions at any time using either the chat feature or the Q&A tool, and we will address those at the end. And with that, Dr. Curseen, please take it away.
Okay. Thank you. I appreciate you having me and my colleague, Dr. Ali Zarrabi, presenting today concerning the role of supportive and palliative care in oncology. Let's see. Having trouble advancing our slides here. We currently have no relevant disclosures, unfortunately. So today we're going to start off with just a brief overview of what exactly is palliative and supportive care in oncology, and then Dr. Zarrabi is going to launch into the literature and what's coming in the future. So I always like to start off with a common definition. How our profession defines palliative care is we're just a subspecialty of medicine that specializes in the care for people living with serious illness. We focus on providing relief from symptom and stress of that illness, whatever the diagnosis is, and our primary focus is to improve the quality of life for both patient and family. We come as a team of doctors, nurses, and other specialists, and we work in conjunction with a patient's doctors to provide an extra layer of support. And it's appropriate at any age and any stage in the serious illness and can be provided along with curative treatment. So who is supportive and palliative care for? So that's our formal definition. Well, in 2016, the American Society of Clinical Oncology put out a statement that said, inpatients and outpatients with advanced cancer should receive dedicated palliative care services early in the disease course, concurrent with active treatment. Referral of patients to an interdisciplinary palliative care team is optimal, and services may be complemented with existing programs, and providers may refer family and friend and caregivers of patients with early or advanced cancer to palliative care services. So in 2016, the American Society of Clinical Oncology recognized the importance of these services for patients who are going along their cancer journey to mitigate suffering. So those are our formal definitions, but what do we actually do? What is palliative care in oncology? Well, in our clinic, we focus on symptom management, social support, spiritual support, care coordination, assistance with the difficult decision-making, and advanced care planning. So I like this picture because for many of our patients, the diagnosis and the care is coming at them very quickly, and they're supported in wonderful cancer centers, but it's impossible to be everything to everyone. So what we actually are is that support under the bridge, and as I like to tell our patients, sometimes we are medical work caulk. So what do we really do? So in supportive and palliative care, we treat the experience of the cancer journey as the primary focus. We ask them to direct the course of treatment, and we serve as guides and change in direction as the direction needs to change. The supportive and palliative care model is focused on that suffering is the primary entity, and our primary goal is to improve that suffering. We treat the distressing symptoms as entities in themselves, and therapy is medically indicated if it controls symptoms. So there's no limits to any of the therapies that we recommend as long as it's controlling the symptoms. We view the patients as complex beings comprised of physical, emotional, and social, spiritual dimensions. The treatment has to be concurrent with the values and beliefs and the concerns of the patient and family, and our goal is to enable them to live as comfortably as they can during the journey. We operate in a place often when evidence-based medicine fails, and we feel very comfortable operating in that gray, and we are willingness to allow patient and family set the goals, and we spend a lot of our time working through uncertainty together. Oftentimes, it's difficult because palliative care is very linked to hospice care for patients to sort of understand the difference or how to kind of explain it to them. So both palliative care and hospice care focus on providing comfort, reducing stress, symptom relief, and providing physical and psychosocial support. And with a palliative care service, though, when we're practicing palliative care primarily, it occurs at any stage of the disease and can be given at the same time as curative treatment. It typically happens in the healthcare setting wherever the person is, and it's less reliant on family and caregivers and volunteers. Hospice care is actually an insurance benefit. So when I'm talking to patients, I explain that although you're receiving palliative care, not all palliative care is hospice, but all hospice is a form of palliative care. And when you're approaching the end of your life, the vehicle by which we deliver the palliative care to you is through hospice. Usually, and under hospice care, the way it's currently defined, it has often excluded what we call curative treatment. I don't like that term because what it actually is saying is that hospice care will focus on care that's going to promote comfort, but it no longer focuses on care that is currently no longer helping. It occurs often in the patient's home or possibly in a facility when the symptoms aren't managed like in hospice hospitals, and it relies heavily on family caregivers and volunteers. And you may hear later on in the presentation that even the expansion of hospice care and providing it along with concurrent care is a new Medicare program, and I think possibly going to be the future of hospice, allowing both cares to happen at the same time as they do in the pediatric world. So where can they receive it? So primary and supportive and palliative care is handled in oncology offices all over the country. Every time an oncologist spends time explaining the diagnosis, managing the symptoms, supporting the family, they have their interdisciplinary team focusing on the patient. They're delivering primary palliative care. Specialty supportive and palliative care is when you send the patient to our interprofessional team, where the specialist focuses on whole person care, where the patient's needs are extending beyond what can be managed efficiently in the primary palliative care setting. So hospital-based consults, palliative care occurs in outpatient-based clinics like the one in Dr. Zarrabi and I attend to. And as you've probably seen in your own communities, there are community-based palliative care programs where they actually go to a person's home, because oftentimes under treatment, the patient may just have enough energy to get to oncology and to get to homes, but having multiple appointments can be burdensome. So the interprofessional team, why is this so important? In order to manage somebody who is suffering and somebody with serious illness, you can't do it alone. So just having one provider, particularly a medical provider, is not well equipped to manage all the psychosocial needs. So this is why we come in a team, and they're equally vital. Tending to somebody's spiritual care and spiritual distress can also be a barrier. It can be a barrier to treatment. So in the interprofessional team, what you should come to expect, and Dr. Zarrabi will explain a little bit more about the variations around the country. Usually there's a physician or advanced practice provider. We have nurses and care coordinators, social workers and mental health providers, chaplains or spiritual health clinicians, a whole army of staff making the logistics work, and often volunteers. And then some programs, depending on how well they're funded, may have pharmacists, music therapists, and other nutritionists, physical therapists, and other providers incorporated within those clinics and teams. The barriers to having those teams being more expanded just depends upon funding, because the billable providers, the physicians, advanced care practice, and the mental health providers usually are the financial supports for the team, and community-based palliative care programs that often do in-home palliative care, as well as linked to hospice agencies who are providing that care with the palliative care team. They are borrowing the interprofessional team from the hospice team in order to provide outpatient palliative care, and that's how that's subsidized.
Dr. Curseen, excuse me, it does not appear your slides are advancing.
So what I'd like to say is, in supportive care, the goal of your patient is our goal. Now I'm going to stop sharing and turn it over to my colleague, Dr. Ali Zarrabi.
Thanks, Kim. I'm going to share the presentation right now. I imagine you can all see this. If you can't, someone will let me know. So let's talk about some other objectives for this talk. So I'm seeing something in the chat. Great, slides are visible. So let's talk about the evidence supporting the integration of palliative and supportive care into oncology practice. And I also will discuss the breadth and depth of what supportive oncology is and hopes to be in the future. So first, let's describe the evidence. I first have a quick disclaimer, and that is that palliative care is both the oldest form of medicine and the newest form of medicine. So what do I mean by oldest? Since humans have been taking care of sick people and dying people. It's part of what makes us human. And it has been a constant thread through the history of medicine. The word palliative means to cloak. It's a newer term that we have for this kind of care. And it's also the newest subspecialty of medicine, formed in 2008. So we are now operationalizing this very human, enduring thing that we've all been doing and trying to make a science out of it. So when you meet a cardiologist, they are experts in the heart, or a gastroenterologist are experts in the GI system. Hospice and palliative care doesn't focus on an anatomic part of the body or a specific kind of, let's say, an oncologist who focuses on ways in which cells replicate. It's really what's called by sociologists a charismatic movement, which is a movement in response to perceived intolerable situations or experiences. About 100 years ago, less than 100 years ago, people were dying in America and in the UK, where this was actually created as a field without the support that they needed. So hospice was created, and now palliative care is expanding, and now supportive oncology is expanding in response to perceived societal needs of a growing population of cancer patients with unmet physical, emotional, and spiritual needs. One example of that is now we as oncologists, as APPs, as palliative people, are now trying to figure out, how do we manage people who develop addictions to the medicines that we prescribed initially to help them. So that's kind of the next frontier of where we need to focus as a field. It's aspirational, it's a philosophy of care. It emphasizes domains that are not traditionally included in reductionist biomedicine. And operationally, it's still very much a work in progress. The field is still pretty darn new. I read this paper in the New England Journal when I was a third-year medical student, and it changed my life forever. This was a paper published by the Temel Group as the senior author, or the first author in this paper, which is a group at Massachusetts General Hospital. She's a medical oncologist. And in this study, they randomized patients with non-small cell lung cancer to a palliative team. Just seeing something in the chat. Oh, okay. to a palliative care team or standard oncology care. They provided what was considered to be gold standard palliative care, meaning they paid attention to the physical and psychological symptoms of these patients, goals of care, decisions regarding treatment and coordination of care. Of note, all of these patients had advanced or stage 4 incurable cancers. And these patients were followed for years. They looked at several patient-reported measures, including composite scores of quality of life, mood and depression scores. They looked at healthcare utilization, such as chemotherapy at the very end of life, whether they were enrolled in hospice and how long they were enrolled in hospice. They also looked at survival. They looked at baseline questionnaires before they were randomized, and the primary outcome was looking at changes in quality of life and mood after 3 months. So patients who received palliative care in addition to oncology care had improvements in mean quality of life scores, which was expected, and lower rates of depression. Many of those patients, unsurprisingly, died over the course of this study, and those who did die were more likely to receive aggressive care at the end of life, and they were less likely, well, let me add one thing, those who were in the oncology group without palliative care who died were less likely to have their preferences listed in their electronic medical record. And most fascinatingly, and this is what got so much notoriety for this paper, was that the patients in the palliative care arm lived longer by several months. And this is the Kaplan-Meier curve that made history for this field. So in this one particular study done at this one particular institution, early palliative care integrated with standard oncology care in patients with this one diagnosis had improved quality of life, mood, and less use of aggressive care at the end of life, and interestingly had longer survival. 9 years later, looking at outpatient palliative care specifically among patients with advanced cancer, a group conducted a meta-analysis and systematic review in which they found among patients with advanced malignancies who were seen by outpatient palliative care teams, and they found 8 randomized control trials and 2 cluster randomized trials, looking again at patients with advanced cancers with some degree of integration into standard cancer care, whether that was under the shared umbrella of an institution like Emory, or oncologist and palliative doctor were sitting side by side in the same clinic. This is how they defined integration. And what they found was that integrated palliative care and oncology showed improvements in quality of life, symptom burden, and also survival in this meta-analysis as well. So how does this work? Like, how does palliative care work, right? This, again, I mentioned it's aspirational, it's a philosophy of care. How do we actually do it? So a group went and did a content analysis of the documentation from that Temmel paper that I initially described. And they identified 3 key elements of what those doctors and APPs were doing. They were managing symptoms, they were strengthening coping, and I put that in bold because I'm going to return to what coping is, and cultivating this illness understanding and prognostic awareness, by which I mean frank conversations about death and dying and how to create a life of meaning and purpose that's consistent with one's values in the setting of all of our inevitable deaths. How do we make sense of life? How do we make sense of death? How do we make sense of this thing that fell upon us, this cancer diagnosis, which we were not anticipating? How do we think about going to work, engaging in intimate relationships? How do we think about God, if we do believe in one, or spirituality in the context of this life-threatening illness? And that's most of what they were doing. Again, going back to the how are these benefits happening? So the Temmel group did another study in which they also included patients with gastrointestinal malignancies, and the group analyzed data from 3,000 visits in that particular study. And again, those were the things that they found: coping, sitting with treatment decisions, and advanced care planning. They found that patients who had more visits addressing coping had better quality of life scores and fewer depression symptoms. Those who had more visits dedicated to treatment decisions were less likely to initiate chemotherapy at the end of life. And those who had more visits addressing how to plan for the future were more likely to enroll in hospice. This was a presentation I actually watched this morning, and I included it at the last minute. It was a symposium a few weeks ago on psychedelic medicine at the end of life. And this particular physician, his name is Joshua Biddle, he's in California, really described what he thinks he's doing as an outpatient physician. He says, and these are his words, the Trojan horse is really symptom management, but once he is able to get where he can with opioids and other medications, the focus is really on elucidating and highlighting what death and life mean to someone, what medicine and humanity means to someone, what wholeness means to someone, what spirituality means to someone. We create a theatrical space with different kinds of specialists in our clinics where these more existential values and forms of creating meaning and purpose are highlighted. So now let's discuss the breadth and depth of what supportive oncology is. So you'll hear palliative and supportive, sometimes interchangeably, sometimes not. So why do we do that? So some will say that supportive oncology is a more inclusive term for all of the multidisciplinary services, as opposed to specialty palliative care, which is what Dr. Curseen more specifically described, and what that CAPC definition at the beginning was, which is a specialist form of medicine. And people also tend to associate palliative care with end of life and hospice. So when we say supportive oncology, technically this also includes acute care, rehabilitation, long-term survivorship, as well as end of life care. Many outpatient practices have changed their name to supportive care, including our clinic, for a variety of reasons. One of which is also across the board you'll find in qualitative research because of the stigma related to getting people's feet in the door to see palliative care. There are ongoing debates in our field about what we should call ourselves for that reason. So Dr. Curseen brought up the definitions of our field. We're going to revisit them one more time and focus on the word approach. Remember, palliative care is an approach, not necessarily a specific way of delivering care. For people with a life-threatening illness, whatever that means, that's a very broad kind of statement. That can be anyone with a cancer diagnosis, even if it's curable, including the prevention of potential suffering down the road, so it can be preemptive. So this really highlights that if people feel like this person or this family member is going to unravel as a result of their cancer diagnosis or whatever illness they may have, it may make sense to get palliative care on board earlier. The other definition below highlights that it's appropriate at any stage and at any age. So it's not just for geriatric populations. Our Winship providers on this call will certainly know that. I have more 20 and 30-year-old patients in my clinic than 80 and 90-year-olds by far. And at any stage includes long-term survivorship. Many of you know that your cancer survivors may have similar forms of suffering as your patients who are nearing the end of their lives. And that doesn't necessarily exclude them from seeing a palliative care specialist. So thinking of supportive oncology in this way and acknowledging the broad definition of palliative care, really, I think of them as being the same thing, and that the only difference between them is stigma. This is what may make supportive care in the broadest definition possible somewhat different than the clinical practice that Dr. Curseen and I describe. So supportive care in oncology, according to some, also includes nutritionists, pain specialists, PM&R physicians or physiatrists. It includes things like transfusions or even antibiotics for a neutropenic fever, stoma care. All of this is supportive, not necessarily directly addressing the cancer itself. It also includes attention to prevention, survivorship, palliation of symptoms, and bereavement. Depending on the supportive oncology practice, they may include all of these things and some may not. And that depends on speaking to the providers and clinicians at your own institution and seeing what they do and what they don't do. The Multinational Association of Supportive Care in Cancer notes that patients should really be wary of the term palliative care because it's really a subset of supportive care. I disagree with this. This assumes that we know what palliative care is and what the scope and practice is. And in truth, we don't. It's still evolving. And because it's still evolving, and this is, I think I really want to hone in on this slide, palliative care is not standardized in the United States. I don't think it's really standardized anywhere practically. So one hospital's palliative care service may be, let's say, a social worker, and that's it, who primarily enrolls patients in hospice. A palliative care service in Atlanta, for example, not Emory, is predominantly APPs who do inpatient consultative work regarding goals of care. Our hospital, Emory, is much more robust. We have an inpatient hospice, several inpatient hospices, inpatient palliative care consultative teams. That includes chaplains, APPs, social workers. We have, where Dr. Curseen and I practice, a robust outpatient team caring for patients from the time of diagnosis through long-term survivorship and through the end of life. And at Emory, we even have a multidisciplinary pain board made up of interventional radiology, anesthesia pain, psychiatry, addiction psychiatry, psycho-oncology, and palliative care to discuss complex cases. So we are, I would say, a pretty well-developed field. Other institutions are also doing interesting work. Some have dedicated home-based services. UCSF is one of them, where their palliative arm actually goes to people's homes. Mount Sinai in New York has an inpatient palliative care unit that's separate from hospice. So let's say you have a cancer patient who comes in with intractable pain. That patient would not be admitted to the med-onc service. They'd be admitted to the palliative care service, where the palliative care clinician is the attending of service. Duke has a hybrid service where their med-onc service is actually staffed by a medical oncologist and a palliative care physician, and they split the service in half. So patients who are there, let's say for induction chemotherapy, obviously will be seen by a hematologist oncologist, and those, let's say, who come in for pain or nausea or a bowel obstruction, they may be typically staffed by a palliative care physician instead of an oncologist. Other palliative teams also have psychologists or pharmacists, and I hope that Emory will also join the fold in incorporating those specialists into our palliative team. So the summary of this slide is we're in the process of developing national standards for this approach to care, and it is still a work in progress. 10 years ago, when we were describing what palliative care is, this was the classic slide that was used. And early in the diagnosis, the focus was on cure. And when it wasn't on cure, then it was more on palliative until inevitable hospice would ensue. And then once the patient was dead, then our teams would be available for bereavement care for those who are grieving the loss of their loved one. Many things have changed this model. This brilliant New England Journal piece now from almost 2 years ago highlights that a lot of our patients with advanced diseases are living for a really long time. Our melanoma patients, even our non-small cell lung cancer patients, within the era of targeted therapies, so many patients are living with what are quote unquote terminal diagnoses for years and years, and some may have no evidence of disease to the point where one day we may say, are you cured? This was highlighted by Dr. Temmel's group at Mass General about the challenge of prognostic uncertainty in the modern era of cancer therapeutics. It's really hard for me, and for I would say any human right now in the world of cancer care, to really know when someone's going to die until someone becomes much more frail. And the suffering is complex and it can span the illness course. For the clinicians on this call, this I'm sure is intuitive to you. This paper published this year, just a few months ago in Cancer, highlighted that patients with AML who presented to, again, Massachusetts General Hospital, where much of this work is being done, 1 month after their diagnosis of AML, over 1 in 4 of them had PTSD symptoms. So high rates of intrusion, high rates of avoidance, and hypervigilance. We talk about PTSD, I would say, not super commonly in our fields, either oncology or palliative care. And it's becoming much more common in our work to see the result of trauma after a life-changing illness. So in this paper, it's pretty alarming. 28% probably meet criteria for PTSD just after diagnosis. But what about people who are post-treatment? So these are patients who are not on treatment, not just diagnosed. In this large study in Canada, where they looked at 10,000 adult cancer survivors who are, again, done with treatment, over 8,000 of them out of the 10,000 reported unmet emotional, physical, and practical domains that were not being met. So how do we think of what palliative and supportive care is now in the 21st century, particularly with cancer illnesses? So on the one hand, we think about cancer-specific management, and that's obviously chemotherapy, radiation therapy, targeted therapies, from proton therapies to immunotherapies, to tyrosine kinase inhibitors, to surgeries. And then we have this space where palliative and specific disease management care overlap, such as transfusions, which happen in both even comfort care settings and classic oncology settings, to anti-nausea drugs, pain medicines, antibiotics. And now we're entering this domain kind of similar to what how infectious disease was approaching HIV in the early 90s, when people started to survive with better treatments. So now we think about quality of life and symptom management and existential concerns and emotional support in the context of rehabilitation and survivorship, as well as hospice, end of life, and bereavement. And this really rings true to so many palliative doctors right now, caring for people, even with, again, I'm repeating myself, but just to underscore this, incurable cancers who really need rehab more than they need hospice. And even among our patients now, and you've seen this too, with no evidence of disease, we had a patient die just a few weeks ago, and we only knew him in the context of survivorship, where he had no evidence of disease, where we were tapering his opioids, focusing aggressively on rehabilitation, going back to work, gaining a sense of normal, only to have a disease recurrence and then die 1 month later. So this part of palliative care is the space in which we, in the next decade, have to really fine tune and hone. So what's next in our field? So first is scalability. There are more and more people who are chronically ill with multiple diseases living for longer, including cancer, including advanced cancers, and the number of chronically ill and dying Americans is increasing, while the workforce is not increasing to the degree that we need to provide that care. So how are people trying to, at least in 2021, address this? The first is primary palliative care, which is training non-specialist clinicians to have some basic knowledge in symptom management, communication, and end-of-life care. Many hospitals are now staffed not just by residents, but a huge role is being played by APPs. And I think this is an important space where we can focus on nurses and nurse practitioners and physician assistants, physician associates, to really gain some degree of expertise in this field, because there aren't enough Kim Curseens or myself to go around. Integration of novel therapies. Patients are requesting more cannabis-based medicines. This is an inevitable part of our medical landscape that's coming, and figuring out how to incorporate that into oncology care in the safest manner possible is a priority. And psychedelic-assisted psychotherapy, which will begin shortly at Emory, I personally believe is the future of this field of specialty palliative care, which is not the scope, which is not really the focus of today's presentation, but it, I think, will be over time. And finally, it's refining these coping-based strategies. So how do we deliver trauma-informed care across the cancer continuum? How do we manage comorbid addictions and substance use disorders in our cancer patients throughout the illness course? How do we collaborate with psychiatrists and other specialists, either through referrals or being under one roof? And what is the best model of care for that? And how do we help people cope through long-term survivorship and no evidence of disease, when so many of them live under this kind of sword of Damocles and this fear that their cancer may recur, or they may never become the person they were before their cancer diagnosis. And that's it. I'm going to go back to this slide right here and open it up for questions.
Thank you, Dr. Zarrabi, and thank you, Dr. Curseen. We had a question that came up in the chat earlier in your presentation. It says, this is from Dr. Gatcomb. Are these services available to all Emory Oncology patients, regardless of which campus they are treated at?
I'm sorry, Javier, do you mind repeating the question? You've cut out a little.
My apologies. It says, are these services available to all Emory Oncology patients, regardless of which campus they are treated at?
Absolutely. We have an open access clinic. Our palliative care clinic and supportive care clinic actually serves all of Emory Healthcare. So it can be accessed by any provider within Emory Healthcare. And but particularly for Winship, we include all Winship providers and ESA if they're being treated here on campus. So there's no barriers. We've leaned heavily into telemedicine. So because of that, that's allowed us to reach people further, all the way up to the Georgia line. So that has been one of though this year was tragic, it was one of the good things that came out of COVID. It actually allowed us to expand our access.
You answered a question I had for you, and that was exactly that. How is telehealth playing a role in your practice? So thank you for addressing that. I have a quick question for Dr. Zarrabi, something that you had touched on in your presentation. You had mentioned that you were seeing, palliative care or supportive oncology is not just for the older patient, that you're seeing, many younger patients in your practice. Do you have an understanding as to why that might be? Is it that a younger patient understands the role of supportive oncology, or what may be the reasons for that?
So this is speculative. I think sometimes patients wish to see us and they request for appropriate providers, and other times providers need extra support. And young adult cancer patients, even young adult cancer survivors, consistently across, and this part isn't speculative, among many health services researched papers, demonstrates that people who are younger have more unmet needs, or more perceived unmet needs. And that can also be a reason why they are referred to us. Obviously, there are patients who are older who also need our support. So we see patients across the age spectrum. I brought that up because many clinicians have asked me, it must be really hard taking care of such a population of older people. And I say, well, no, most of my patients are quite young. So I wanted to dispel that myth.
And also geriatricians, we have an active geriatric practice here, have some palliative care training. So there's another vehicle for an interprofessional clinic, and for patients receiving clinical trials and or difficult chemotherapies tend to skew a little younger. And so a lot more symptom management, and the interest in alternative therapies like medical cannabis might be spurring some of that on as well.
Great, thank you. We have a question on our Q&A. It says, do you recommend breathing exercises and other yoga techniques? Who would like to tackle that?
Sure, yes. We have social workers, licensed clinical social workers who are also therapists. We have 2 of them in our practice in the outpatient setting who are trained in guided imagery and breathing techniques. So for our patients who wish to do so, and maybe we would recommend that ourselves as the primary providers, patients will see our trained therapists independently of us, and we'll do breathing work, guided imagery as a separate session entirely. We don't do yoga in our clinic specifically, but I certainly provide a list of massage therapists, oncology massage therapists, yoga, Tai Chi in the community where people can pursue those resources.
And the future of Cancer Center at Winship will have a whole floor dedicated to integrative oncology, and the plan is to expand those services so patients, at least within the Winship system, will have a place to go to explore those other therapies and to support them. So stay tuned.
That's wonderful. It's good to hear that that's coming in the near future. Have a follow-up question regarding the having availability for Emory and Winship physicians. How would an Emory oncologist or Winship oncologist refer patients to your clinic?
We are actually, if you do an internal referral in our medical record through Cerna, it comes up supportive care and palliative care. Both of those pathways lead to us. You could also have your staff refer to the supportive care admin pool directly and request a consult. What we require is a diagnosis. And we also like to know what you would like us to focus on. We really try to stay within the consultation guidelines for the patient's comfort as well as the referring provider's comfort. We keep a very close collaborative relationship.
We have another wonderful question in the chat. Someone who works in the medical, Sabrina Furlow, who works in the medical oncology clinic. She says that she finds many patients don't understand the difference between palliative and hospice care. You both touched on that in your presentations. What are some resources available to patients that would explain the difference?
Dr. Zarrabi just put in the chat box, getpalliativecare.org. That's probably one of the best, most patient-friendly websites. And I think, and that's another reason for calling our clinic supportive care. I'm a palliative care doctor, but what I actually do is provide support. So I feel that is a better description of what we do. And most people are open to supportive care, and then we do further education once they get there.
I have another question here in the Q&A tool. It says, how do you manage insomnia in patients undergoing any type of therapy? Or how do you address insomnia in patients undergoing particular therapy?
We address insomnia in a variety of ways. Of course, we use some pharmacology, but we first start with sleep hygiene. And as much as patients poo-poo that, it can be incredibly effective. The medications that we use tend to time out, and they have other side effects that aren't very helpful long-term. So developing good sleep habits. Other part is what Dr. Zarrabi went back to, is addressing some of the trauma. What is it exactly keeping you up, keeping you awake? We also take a look at their treatment plans and when they're actually taking their medications. Sometimes it's things that we're using to help, or the things that we're doing, or if they're taking their twice-a-day steroids at 6 o'clock, they're going to be awake. We try to also normalize some insomnia. You're not going to sleep through the night every night, and so making that normal, particularly if patients aren't on a particular schedule. Sometimes we ask them to sort of lean into that sleep schedule because that's not going to be harmful to them. And then, of course, we use a lot of the traditional pharmacology. We try to stay away from the sedative hypnotics like the Ambien or the Z drugs because they tend to be habit forming, eventually not working. And so now your patient's not sleeping, but they can't get off this medication. And they also can, over time, become depressant. So sleep is a really complicated symptom to manage, but it's a large part of our practice. Dr. Zarrabi, did you have anything to add? Please don't give anybody 10 milligrams of melatonin. If it's not working on 5, it's not going to work.
And don't start with Ambien.
All right. Well, one minute. It says here, I'm a current pharmacy resident at Emory and will be completing my oncology pharmacy training here as well. Are there opportunities, current or future, for pharmacists' involvement with supportive oncology here at Emory?
Many palliative care programs actually have pharmacists working with them, as well as hospice programs. So our hope would be, that would be our dream, to have pharmacy incorporated. The gold standard is really the Veterans Hospital, who has a pharmacist that's actually working and counseling the patients. And outcomes have shown that when pharmacists are involved, particularly in controlled substance management, that patients do a lot better, a lot more compliance, and less accidental adverse events. So yeah, so the question is yes, around the country. Do we have opportunity now? No, but that's our final, that's one of our other frontiers that we're going to be working towards.
Well, wonderful. It doesn't appear that we have any more questions from the audience. Thank you everyone for the lively discussion. Dr. Curseen, Dr. Zarrabi, thank you so much for a wonderful presentation today. To our audience, this webinar is being recorded. We will make it available on the Winship website. And with that, just say thanks again for joining us, and have a great week. Thank you. Bye-bye.